Hi, good morning, everyone. Assalamualaikum and welcome to today's session of Breakfast at UMHealth. My name is Adina. I'm from the Department of Primary Care Medicine, and I'm here to introduce Dr. Christine Shamala Selvaraj, one of our new lecturer to the department. Christine is one of our master's candidate that passed our family medicine master's program in 2017. Previously, she did her undergraduate at Malacca Manipal. So she has been a family medicine specialist for nearly 4 years now. She had served in Sandakan, Sabah for 2 years, one of her interesting years, right, Christine? Prior to joining us, she was in serving as FMS in Selangor, in Semenyih. So today she wants to talk about a topic on do we practice what we preach? I think that's very relevant to primary care. We do give out a lot of advice, especially to our patients with non-communicable diseases. One of the important advice we usually dish out is exercise. It has been shown to reduce morbidity and mortality, but do we ourselves practice that? I think let's hear what Christine has to say and probably do our own self-reflection as to whether we practice what we preach. Go on, Christine. The floor
Thank you very much. Thank you, Prof. Adina, for the kind introduction. Allow me to share my screen. Can you see my screen?
Yes, Christine.
Okay, thank you very much, Prof, for the kind introduction. And also thank you to the Committee of Breakfast at UMHealth for inviting me to talk to all of you today on a topic which I feel is very relevant for us to revisit in the time that we are in right now. So the title of my talk for today is, do we practice what we preach? Right? The association between, we're looking at the association between physical activity levels of primary care doctors and exercise counseling given to patients with chronic diseases. Hang on, let me... Okay, this gentleman here is Plato, and he had something to say about physical activity way back in 380 BC. And he was quoted to say, "The lack of activity destroys the good condition of every human being, while movement and methodical exercise save it and preserve it." So this will set the tone for the rest of the talk for today. Now, we all know that regular physical activity and exercise are extremely vital for our well-being and health of people of all ages, and it does reduce morbidity and mortality from many chronic diseases. And chronic diseases, particularly the non-communicable ones, are a huge problem globally, as it causes 7 out of 10 deaths, according to the WHO. And in Malaysia, these NCDs contributed to 71% of premature deaths, according to the NHMS of 2019. And a big contributor here is physical inactivity, which is the 4th leading risk factor of mortality globally. So physical inactivity actually is the original pandemic, and we have to deal with essentially 2 pandemics right now. So some definitions to help us revise. Now, physical activity refers to any bodily movement produced by skeletal muscles that require energy expenditure. And this refers to any activity that we do throughout the day, including leisure activities, transport, going to and from places, activities that we do as part of our work as well. Whereas exercise is a specific subset of physical activity that's usually planned and structured, and it has an objective of improvement and in maintaining physical fitness. So this is an outline of what I'll be talking about today. I'll start by talking about the benefits of physical activity and what are the recommendations of physical activity and how we are all doing in terms of physical activity, and as well as how primary care providers or doctors are doing in terms of physical activity. And then exercise counseling, which is usually where primary care providers are well equipped to provide to patients, as we are usually the first ones to encounter these patients in the early stages of their chronic diseases. And then I'm also going to share a little bit about a study which I did as part of my thesis back in 2016 under the supervision of Dr. Nordiana Abdullah, also from the Department of Primary Care Medicine. So the benefits of physical activity, it's been proven to be an effective form of prevention and therapy for most chronic diseases, and it is particularly beneficial for patients who have cardiovascular diseases, diabetes, cancer, and it has been proven to help prevent hypertension before its onset. In terms of mental health, which is particularly relevant today, physical activity helps to reduce symptoms of anxiety and depression as well. It also helps to maintain your weight, gives you a good sense of well-being, that rush of endorphins that you get after a good workout, that really makes you feel good. And then in the context of COVID-19 today, it could have a preventative measure here, as there was a paper published in Spain recently. It was published in late 2020, and it talked about possible ways physical activity and regular physical activity can help in terms of COVID-19, where those who practice regular physical activity tend to have changes to their immune system, in their innate and adaptive immunity. It equips them to actually stimulate certain pathways, especially in terms of interferons. And this has ultimately an antiviral, anti-proliferative outcome. And this can be beneficial in the initial infection stages of COVID, and even later on in complications when patients possibly get the cytokine release storm. So this is relatively new, and it does warrant further research and to go into details about what specific exercise regimens may be particularly beneficial for those who have COVID or as prevention. Right, all the recommendations. These are the latest recommendations according to the WHO from 2020. So I'd like to draw your attention here. So let's look at adults aged 18 to 64. So the minimum is at least 150 to 300 minutes a week of moderate intensity aerobic physical activity. So the bare minimum would be 150 minutes. And when we talk about moderate intensity, we're referring to physical activity that does increase your heart rate, does increase your breathing, but you're still able to talk quite comfortably. Either that or at least 75 minutes of vigorous intensity aerobic activity. So when it's vigorous activity, yes, your breathing and heart rate increase even more so, and it's difficult to speak. That's how you know you're engaging in vigorous activity. So it's either moderate or moderate or vigorous intensity, plus at least 2 sessions a week of strength training. And these exercises should ideally strengthen all muscle groups. Then for older adults aged 65 and above, essentially it's the same as the recommendations for younger adults. However, it'll be good to incorporate multi-component physical activity that emphasizes and focuses on functional capacity and strength training about 3 days a week. And this is also useful in the prevention of falls. And if you are pregnant or in the postpartum period, it is recommended that you get at least 150 minutes a week of moderate intensity physical activity, provided there aren't any contraindications. And if you were previously active and used to engage in vigorous activity pre-pregnancy, you actually can continue this through pregnancy. And then we look at children. Now, children and adolescents in particular have been very badly affected by the pandemic due to closure of schools and lockdown impositions. And this group of our population actually do need a lot of physical activity in a day, need an average of about 60 minutes a day of moderate to vigorous aerobic physical activity, and also another 3 days a week of activities that strengthen their muscles and bones. So the key message here is actually everybody benefits from physical activity, and the aim is actually to prevent being too sedentary. So here I would like to ask all of you, let's ask ourselves, how many of us have complied with these bare minimum requirements in the last 7 days? If you would like to share your answers in the chat box, you're most welcome to do so. We'd love to see your feedback, right? And for those who aren't very physically active to begin with, that's fine. It's good to start somewhere. Some physical activity is better than nothing at all, right? And it's always good to start with small steps and work your way up gradually in terms of increasing the frequency, duration, and intensity as well. Right. Now, how are Malaysians doing in terms of physical activity? So here we have an infographic from the NHMS from 2019. And 1 in 4 adults in Malaysia are physically inactive. And this is in keeping with the global statistics as well. And 28% of females are physically inactive. And in the older population, 75 and above, about 59%. And nearly 40% of students. And why does this happen? The usual reasons, even pre-pandemic, are usually due to insufficient time. You know, you've worked the whole day and then you come back, you're tired. There just isn't enough time at the end of the day for any designated or specified time for exercise. And many are still just not aware of the benefits of starting physical activity earlier on in preventing chronic diseases. Then we have the pandemic of COVID-19 on top of that to further aggravate matters, which has resulted in the closure of parks and gymnasiums, and many outpatient rehabilitative services too were either suspended or drastically reduced. And with the closure of schools, and that's made a huge impact on children, right? And even when schools were open, physical education classes were mostly suspended. So that just has brought our physical activity levels down quite significantly. And healthcare workers, how physically active are healthcare workers, right? So locally, there was a study conducted in the Klang Valley amongst primary care doctors in the government sector, meaning in the government health clinics or clinic kesihatan. And it was found that 51.4% of these primary care practitioners were reported to be physically active. And how does that compare with our colleagues around the world? In the US, ranges from only about 25.9 to 27%, and in Nigeria, about 20%. Whereas in other countries like Saudi Arabia and Canada, they seem to be doing a little bit better. Now we come to exercise counseling. So exercise counseling is something that primary care providers are quite well placed to provide to our patients, because we usually see them very earlier on, and we're usually the first to see them before the onset of any complications. However, literature has shown that about a third of primary care providers find it very difficult to counsel patients on good behaviors that they themselves struggle with, such as exercise. Exercise is one of them. And there is evidence to show that doctors' own habits of exercise are an important predictor of how they will counsel their patients on exercise. And apart from that, some of the common barriers to exercise counseling include a lack of time during consultations, and also a lack of knowledge or training in this aspect. So there is research abroad that shows that doctors who are physically active tend to give exercise counseling more often to their patients. And we wanted to see if that association was true here, to take into account some of the cultural differences here. Right. So the general objective of the study was to determine any association between the levels of physical activity of primary care doctors in private practice and their exercise counseling habits to patients with chronic diseases specifically. Right. So we wanted to see, so specifically, we were going to look at levels of physical activity amongst these primary care doctors in the Klang Valley and Penang. It's an urban setting. To look at frequency of exercise counseling given to patients with specific chronic diseases, and then to determine any associations between these physical activity levels with counseling, as well as confounding factors. So this was a cross-sectional survey done amongst primary care doctors in private practice. And this was preceded by a pilot study in Universiti Malaya Medical Center. So who did we involve with this study? It was primary care doctors in private practice, either full-time or part-time, from KL and Selangor, who were members of the Academy of Family Physicians Malaysia, and also in Penang, who were members of the MMA and attended the Penang GPs conference then in 2016. The sample size required was 265 after calculation, and we used universal sampling. So this is a flow chart of the study, right up from the proposal to the ethics approval. The pilot study was done. We obtained permission from the relevant authorities before the questionnaires were distributed by post and in person as well. The data was analyzed using SPSS version 23, and then the paper was written up. Right. So the study tool given to the participants was a questionnaire made up of 3 parts. So the first part looked at their social demography. So we looked at age, gender, the BMI, smoking status, any chronic medical diseases, their years working, and their highest qualification. The second part looked at the frequency of initiation of exercise counseling to patients with these specific chronic diseases, which I will show you in a while. And the third component assessed physical activity of these doctors using the International Physical Activity Questionnaire, or the IPAC. And this measures physical activity levels in met minutes per week. So the IPAC, I think some of you may be familiar with this questionnaire. It's been validated in 12 countries, including Malaysia, and it looks at 4 types of activities, namely vigorous, moderate activities, walking, sitting, and they have a specific quantity assigned to it for the purpose of calculation of the scores at the end of it. So after these scores are calculated, they're further categorized into 3 categories, which is low, moderate, or high. So according to the IPAC scoring protocol, if somebody scores either moderate or high levels of physical activity, they are considered to be physically active, broadly. And if it's low, that means the person is physically inactive. Right? So when we analyze the data, we use descriptive statistics to look at physical activity levels of primary care doctors and their frequency of exercise counseling. And then we performed simple regression analysis followed by multiple regression analysis. So we had 272 respondents out of the 879, not a very good response rate. This is the flow chart leading up to the total number of respondents. So this is the summarized social demography of our respondents. The median age was 34. Most of them were female and either overweight or obese. Most of them were non-smokers, and a few had some underlying comorbidities, particularly obesity. Most of them were undergraduates, and they saw a mean of about 40 patients a day. So how physically active were these respondents? 50% of them had moderate levels of physical activity, and about 24.3% of them had high levels of physical activity. So in total, 74.3% of them were found to be physically active, and about a quarter were physically inactive. How often did our respondents provide exercise counseling to patients with these chronic diseases? So the chronic diseases here sampled were cardiovascular diseases, hypertension, diabetes, obesity, and dyslipidemia. And most of them answered often or always. So from the scale of never, rarely, sometimes, often, and always, we were further categorized into 2 categories for the purpose of the data analysis. So if someone never, rarely, or sometimes counseled, that would be classified as rarely initiates counseling. Often or always were classified together as often initiates. So this is the simple regression table analysis that was done, and we found a significant association between physically active doctors offering counseling of exercise to patients with cardiovascular diseases and hypertension. Right? So about 3.2 and 2.2 times respectively. The confounding factors were analyzed as well, and we took the ones which were significant with a p-value of less than 0.25 and included it in the multiple regression analysis. Age, gender, smoking status, BMI, number of years working, having a postgraduate qualification, and also looking at the number of patients seen per day. And this is what we found from our multiple regression. So ultimately, we found here an association between doctors being physically active, offering exercise counseling to patients with cardiovascular diseases, about 2.7 times more likely here. Right. So what does this mean, and how do these findings compare to other papers? So in terms of physical activity, we found here that 73.4% of primary care doctors were found to be more physically active, a bit higher than the study done amongst Malaysian government doctors, which is 51.4%, but it's still more or less slightly lower actually than the general population. And how do we compare with our global counterparts in terms of physical activity? So it tends to vary. An Estonian study found that 92% of their physicians were physically active, compared to only about 20% of Nigerian family physicians. In terms of frequency of exercise counseling, there was a bit of a varied range here, from 62.2% to 91.6% for all the chronic diseases we sampled. However, these rates are actually quite comparable to studies done amongst GPs in Northern Ireland, Japan, Korea, and Estonia as well. And it still appears to be higher than exercise counseling offered by doctors in the government sector. In terms of associations, so we did find a significant association, however, only to patients with cardiovascular diseases. And this was also similar to findings by studies done by Lobello and colleagues, Howe and colleagues, Abrams and colleagues, and Frank and colleagues. So these are very experienced sports physicians who have published a lot of papers on this. We also saw, incidentally, there was a higher frequency of exercise counseling amongst doctors who had postgraduate qualifications, and that could be because of the knowledge and experience that they have, which is more than that of undergraduate doctors. So, in all honesty, there were limitations in this study. A lot of as with other studies, many of the questionnaires assessing physical activity were self-reported. So there tends to be a bit of reporting bias, where physical activity may be actually lower than what is actually reported. And there wasn't a database to determine the exact number of primary care doctors practicing in the private sector. So there may have been many that were missed out in the process. At the time, this was one of the earliest studies to study primary care doctors in private practice itself. And this can always pave the way for more research into health and well-being of doctors in private practice in future. So we concluded from this study that primary care doctors with increased physical activity were more likely to initiate exercise counseling to patients with cardiovascular diseases. So what we can learn from here is that it would be a good idea to remind ourselves to be more physically active, and not only for the betterment of ourselves, our family members, but also it may rub off on our patients as well when we see them during our consultations. And perhaps in future, when restrictions are further lifted and we're able to have more campaigns and roadshows in future, this could be a good opportunity to collaborate between the MOH and MOE with the private sector in having more programs in future. So this is just a short slide here. This is actually from the American College of Sports Medicine, and there are some activities which were specifically put here for the purpose of COVID. So if you know anyone who is still a bit reluctant to go out to exercise and does not know how to do it indoors, these are some suggestions. So aerobic activities can be done indoors, where you can actually put some music on and just walk briskly around your house, up and down, or down the stairs. This is what I do at home, actually, jog up and down. Although I don't put any music, the silence is actually a good time to zone out and be one with your own thoughts. But whatever rocks your boat, right? You can actually dance to your favorite music. Dancing is a wonderful cardiovascular activity. You can use your jump rope or even do an exercise video. There are literally thousands of exercise videos on YouTube right now, and which are good because a lot of them don't require a lot of space, which is the usual constraint that we have. They don't require a lot of space, not a lot of equipment as well. And if you have any home cardio machines, please use them. I know of many who own stationary bikes bought years ago, and now it's collecting dust and used to hang clothes. So good to use them again the way they were meant to be. Right? And for outdoor activities, yes, if you are comfortable doing so, do start going for a walk or jog around your park again while maintaining social distancing. Come back and wash your hands and wash yourself as well. Or if you prefer, you can always go for a bike ride or garden at home. Now, strength training. Strength training is what many are not too familiar with, and it's a good time to start. There are many apps that you can download, and they show you good videos to take you step by step through all the steps of strength training. And it's a lot easier than using books compared to last time, because they when you take you through the steps, you can do the techniques are correct, and you prevent injuries as well. Yoga is also a good way to get your strength training in. Some of the apps that you have, such as 7 Minute Workout or even Fitness Blender, these are good apps. Even those who it'll be good to get a fitness tracker if you can, if you don't have one already, or for your patients as well. There are a lot of inexpensive trackers, and they usually come with apps which can be linked to your smartphone. All right, and so it's a good way to start having these targets that you can achieve every day, and you become more competitive with yourself. Right. A few ways to sneak in some physical activity on a daily basis, if you don't have time for exercise, would be to, if you can take the stairs more often when you're at work rather than take the lift or the escalator. Start taking the stairs. You can park your car a bit further from where you usually do, that you can sneak in more steps in a day. And that's quite easy with our campus. And another good way to sneak in more steps is when you get a phone call, try not to take your phone call sitting down. You can actually walk up and down while you are on the phone. Just imagine your mother calls you, and she's updating you about all the family misadventures, which auntie said what uncle did what, for an hour. Just imagine after an hour, and you see, voila, you've gotten 6,000 steps already. So that's a good way to get your physical activity in. So I hope this is useful for everyone. These are my references. I would like to leave you all with this saying by Dr. Kenneth E. Powell, a renowned sports physician. And he said, some activity is better than none, and more is better than less. With that, I thank you all very much.
Thank you very much, Christine. That was quite an interesting talk, an eye-opening talk on how you can keep active even though in the current situation. I think you're talking about the lockdown and the inability to access usual exercise areas. You know, I know certain gardens or certain parks are closed during the COVID pandemic. So your study showed that there's no truth in the mantra, do as I say, but just don't do as I do, because it looks like if you don't do, you won't say, and your patient wouldn't do. So, but I have two questions quickly before we hand this over to our colleague at the psychiatry department. Number one is Prof. Tunku Sarah asks, apart from formal weight training, are there any other muscle building exercises that you can suggest or recommend?
Sure. That's a great question. Thank you very much, Prof. Tunku Sarah. So many of us don't have a lot of equipment at home for strength training, such as dumbbells or resistance bands. Resistance bands are actually a very inexpensive and a good way to get your strength training in. But if you don't have any of these, you can actually do sit-ups or push-ups against the wall, using your own body weight. If you don't have equipment, you can use your own body weight. So you can do push-ups against the wall or against the kitchen counter. You can actually also do lunges. Lunges are a good form of strength training for the lower half, for your lower limbs. Planks as well. Planks are good. Planks are very difficult. They look easy, but they're not. And gentler ways of getting strength training into your regimen would be like yoga or Pilates. Right? So I think that's a good way to get your strength training in, just about twice a week, and try to target all the muscle groups in the body, and you'll feel good. Yeah.
Right. Thanks, thank you, Steve. And I think another comment from Prof. Kusara is the sampling of your study. I think she noted that you are recruiting those that are on training, they are doing your postgraduate training, so they might be more self-conscious anyway. But I'm a bit surprised that even their exercise practice is not that high. Is that right?
Yes, that is true. So it just shows that there's always room for improvement. And in our role as doctors, not necessarily just in primary care, it's always good to set an example. So if we are going to be advocates of good, sensible, and healthy lifestyle in terms of our diet and physical activity, these are the most basic aspects. It's always good to start somewhere and actually practice it. And when we do this on a daily basis, we tend to encourage everyone around us to do the same. So, so I think if you haven't done any physical activity in the beginning, it's always good to start somewhere. Start small, and the endorphin rush alone will motivate you to keep doing it. So try to do it every day, and your body will thank you for it one day, and your patients.
Thank you very much. I think endorphins are good for mental health as well, right, Anne?
Excellent. Yes, it is.
Yes, definitely.
Right, great. So thank you very much, Christine. Thank you very much, everyone, for listening and asking your questions. I pass this over now to Associate Professor Dr. Anne Yee. Thank you.
Thank you.
Thank you very much, Associate Prof. Adina and Dr. Christine. We have learned a lot about physical activities. So, right, so hi everyone. We are from the Department of Psychological Medicine. Today, I'm going to introduce my colleague, Dr. Benedict Francis. Is a psychiatrist at the Universiti, Malaya's Medical Center. He graduated from the Faculties of Medicine, University of Malaya, and was selected for the Bright Sparks scholarships to pursue his master's in psychological medicine. Subsequently, he completed a fellowship program in aged healthcare services at St. Vincent's Hospitals, Melbourne in 2019. Dr. Benedict passions is always in the mental health of older adults, particularly with regards to the psychosocial interventions to combat the behavioral and the psychological symptoms of dementia. He is also an active researcher and has involved in several international multi-centers clinical trials involving novels and new antipsychotics and antidepressants. He has also published in several international and regional peer-reviewed journals and presented in international congress. He is also currently the Vice President of the Early Career Psychiatrist chapters of our Malaysian Psychiatry Associations. So today he is going to teach us on the mood disorders among the elderly. So let's welcome Dr. Benedict.
Thank you very much, Prof. Anne, for the extremely kind introduction, and also thanks to Dr. Christine just now for your very enlightening talk and sharing. It's wonderful to be here today at this breakfast talk. So without any further ado, allow me to share my screen. Okay, hold on. Okay, so I'm here today to share with you all on mood disorders in older persons. As we know, we are at an age where we are seeing an increase in the numbers of older persons. We have to live with the fact that Malaysia is an aging nation. In fact, latest statistics actually show that by the year 2030, and that's not too far from now, 15% of our population will be aged more than 60, and that's quite a staggering number actually. So we have to take them into consideration now and improve or ramp up our care of older persons. And one important component of caring for older persons is their mental health. So today I would like to share with you all on the various mood disorders that can be present in older persons. This is the outline of my talk. So I'll be focusing on the two most important mood disorders that affect older persons: late life depression and also late onset bipolar disorders. Now, mood disorders in late life, as I mentioned earlier, is quite frequent in old age, although not so frequently detected. And this is because older persons usually don't really come forth with their mood symptoms. They're not as forthcoming as their younger counterparts, and the presentation of depression can be a bit different. Okay, and also late life depression and late onset bipolar disorder are usually associated with increased medical comorbidities. So they are more often to be having cardiovascular disease and also neurological diseases as compared to their younger counterparts. It's more associated with cognitive decline. Quite a significant portion of them have they either have concomitant dementia, or this mood disorder is a precursor to an eventual diagnosis of dementia. Okay, there's also the risk of suicide, which we have seen increasing, especially in this pandemic as well. And of course, as a result of suicide, and also the disease process itself, increased mortality. Now, I'd like to start with late life depression. Now, late life depression is defined as the onset of depression beyond the age of 65. Some people tend to think of being elderly or being an older person above the age of 60, but this is actually incorrect. At 60, you're still young. Okay, older person, as defined by the World Health Organization, is 65 and above, right? So what's unique about late life depression, or LLD, is that it's a frequent contributor of geriatric morbidity. So it oftentimes contributes to the geriatric giants of immobility, increased falls, incontinence, and also cognitive impairment. And oftentimes we find in our clinical experience, these subset of patients are quite treatment resistant. They don't respond to antidepressant as well as their younger counterparts. And of course, with late life depression, it oftentimes precludes a diagnosis of eventual dementia. And this is seen actually in up to 50% of the cases. If it's not frank dementia, then it's mild cognitive impairment. Okay, and I'll show you later on in the slides to come that the presence of depression actually increases the conversion rate of amnestic mild cognitive impairment into frank dementia. Okay, the presence of depression itself is a strong risk factor to develop dementia, and it's been said in various studies that have been published that it can increase the risk by up to twofold. Now, just to compare the epidemiology of late life depression and also late onset bipolar disorder, you can see here the prevalence. The prevalence of late life depression can be up to 38%, and some studies even posit that it could be as high as 47% in the inpatient population. If you look at the community, it's about 2 to 3%. So the figures you're seeing here in more of an inpatient hospital settings, it can be as high as 38%. For late onset bipolar disorder, much lesser. It's only 0.1 to 0.5%. Now, late onset bipolar disorder is defined as the onset of bipolar after the age of 45. After the age of 50. So it's important to understand these age differences. Okay. Both depression and bipolar disorder affects females most, 52% for depression and 66% for bipolar disorders. Both of them are associated with significant cognitive deficits. So when I say cognitive deficits, I'm not only talking about memory, but also impairment in executive functioning and praxis, as well as orientation, and also social cognition as well. Okay, both these disorders are a challenge to treat, associated with some amount of treatment resistance, which is worrying. And both late life depression and late onset bipolar disorder are pretty under recognized because it's not so hard to pick up. Now, shining the spotlight back on late life depression, how is it different from adult onset depression, which is the onset of depression before the age of 65? So if you look at adult onset, there are strong genetic factors that are present, okay, particularly factors that affect the serotonin transporter at the serotonin neurons in the brain. But if you look at late life depression, not so much genetic factors, but more structural changes in the brain. So if you're seeing more changes over the frontal lobe, over the frontostriatal circuitry in the brain, and also some changes over the temporal lobe as well. For adult onset depression, usually is associated with insecure attachment during childhood, but for late life depression, not always the case, and the index episode starts at 65 and above. Younger adults are more likely to seek treatment, but for those who have late life depression, sometimes they don't even realize they are depressed, and this is because their depression manifests by means of somatic symptoms rather than depressive symptoms. So I oftentimes in my psychogeriatric clinics see my older persons who come in and tell me, doctor, I'm having bad headaches or bad neck pain, and I'm just having this muscle ache. And it is only after a few consultations that we're able to uncover that actually they have been depressed. And once I treat their depression, their somatic symptoms improve. Okay, this is in contrast to younger adults where they quite readily express that they are depressed. Okay, younger adults are more often to also use drugs and substances such as ecstasy, methamphetamines, cannabis, alcohol. We don't really see this with our older population, but they do have a higher prevalence of comorbid medical illnesses. Okay, of course, in our older persons, they have a greater risk for dementia and also more pronounced psychomotor retardation. Now, what's the meaning of psychomotor retardation? It's basically slowing of movement, and this is also related to the vascular burden that is seen in late life depression, affecting the subcortical structures of the brain in people who suffer from depression above 65. That causes them really to have not only slowness in movement, but also slowness in thinking as well. Okay, so the other prominent features of late life depression is that they have more fatigue, oftentimes have sleep disturbances. We find that sleep, especially REM sleep, tends to be more fractured as people age, and this is oftentimes natural. But in people with depression, sleep disturbances become even more pronounced. They have stronger hopelessness, and this also leads to more intense suicidal ideations, but oftentimes they do not speak of this ideation, so it's quite hard to detect, and their suicide methods can be more lethal. Okay, they have more cognitive complaints, okay, a more psychomotor retardation, as I explained earlier, and also a lot more apathy. And apathy simply means the lack of motivation, and also the presence of anhedonia, the inability to experience pleasure. All these are much more frequently seen in late life depression. Now, this is an interesting figure which is taken from the work of Eloxopoulos, which has done a lot of work in late life depression. This basically shows you that there are a lot of medical illness that can worsen depression, and perhaps also has depression as a part of their illness, and this can range from various neuropsychiatric illnesses such as Parkinson's, Huntington's disease, of course dementia, various different types of cancers, autoimmune diseases that have a strong interface with depression, and also the fact that various medical illnesses also can complicate and perpetuate the presence of depression. And these are various medical illness such as obesity, diabetes, cardiovascular disease, coronary artery disease, and also diseases that gives rise to inflammatory states in the brain. And we find that when there's a high inflammation load in the brain, and there's also increasing cardiovascular disease leading to atherosclerosis in the brain, there's an increased incidence of late life depression. So really, when we want to treat late life depression, you also got to treat their concomitant medical illness as well, because there's a very close bilateral relationship between their comorbid medical illness and also their depression. Now, what are the mechanisms of late life depression? So we have these various risk factors. So when you're talking about risk factors, you have biological risk factors and also environmental risk factors. Let's focus on the biological risk factors. So as people get older, they are bound to have more medical illness. So for example, cardiovascular disease, uncontrolled diabetes, hypertension, obesity, high cholesterol, or even the presence of autoimmune diseases. So what's this going to do is that it's going to increase the inflammation in the brain. It's going to increase the production of reactive oxygen species. Is going to cause all kinds of oxidative damage to the brain. And this is also going to increase amyloid deposition in the brain. And we know from research that people who have depression also have accelerated amyloid deposition, and this will therefore predispose them into developing dementia. So when there's this high inflammation load into the brain, coupled with this increased vascular burden as well because of lacuna strokes and silent strokes, this is going to alter the synaptic connectivity between neurons in the brain. It's going to reduce neurogenesis and also going to lead to remodeling of the various dendrites that are responsible for synaptic torque. And we know now that synaptic torque or interaction between the various neurons are essential to maintain a state of euthymia. Crosstalk between the various synapses, that's when our patients becomes depressed. Okay, and this will then give rise to dysfunction in the frontal limbic circuitry. And the frontal limbic circuitry is a very important circuit that connects the frontal lobes with various structures in the basal ganglia. For example, the globus pallidus, striatum nigra, and also the striatum itself. And this gives rise to the various symptoms that are quite unique in late life depressions, such as apathy, executive dysfunction, insomnia, and also fatigue, and the lack of motivation to do things. And as you can see in the blue box there, eventually this gives rise to dysfunction in cognitive control, reward interpretation, and also dysfunction in their salience interpretation. Now, there is a subset of depression in older persons known as the depression executive dysfunction syndrome, which is a pretty distinct entity by itself and has very poor response to antidepressants. Now, this kind of depression occurs in patients who have a lot of vascular damage. Their vascular burden is very high. There's a lot of disruption in their frontal subcortical networks. And as a result of that, they have a lot of apathy, a lot of psychomotor retardation, a very pronounced anhedonia, that means inability to experience pleasure, pronounced disability. They do have vegetative symptoms such as insomnia, loss of appetite, loss of weight, sometimes even loss of libido, and quite surprisingly and quite interestingly also have mild suspiciousness that does not amount to a persecutory delusion. And also quite interestingly, they have less pronounced depressive ideations. So they don't come and tell you, doctor, I'm depressed. In fact, that might be the last complaint that they have, but they have all these other symptoms. It's also important to recognize that these patients also belong to the spectrum of late life depression. Now, also giving a bit more focus to the inflammation hypothesis of late life depression, we see that in patients who have a lot of comorbid medical illnesses, and these patients and their medical illnesses are not so well controlled, they enter into a pro-inflammatory state. This causes the increase of interleukin-1, interleukin-6, TNF alpha, and various other inflammatory marker. And this causes a dysregulated immune system. And we've seen that as a result of that, there is increased activation of microglia and also a reduction of neurogenesis and eventually and ultimately neuronal loss. And you can see how if there's more neuronal loss, eventually it will lead to dementia. Now, we know that tau and amyloid deposition are really key and central in the development of dementia. And studies have shown that even as early as 20 years before the onset of frank dementia, the onset of tau and amyloid deposition has already begun. Okay, and what we know now is that even in people who are depressed, they have increased amyloid deposition in the brain. Okay, one recent study has shown that in people who had increasing amyloid deposition in the brain, they actually had more anxious distress symptoms of their depression during a 5-year follow-up period. Okay, and the presence of depression itself has been associated with a high conversion rate of amnestic mild cognitive impairment to frank dementia. Now, mild cognitive impairment is a state where they have subjective complaints of memory loss, but they do not have frank dementia. So it's more of a pre-dementia stage. So if you do a formal mental state examination, they would score normal scores. So these are the group of patients that we really want to target, because we can really prevent, or we may be able to prevent their progression or their decline into frank dementia if we're able to catch them early. So treating depression is one of the key things that we can do to prevent this conversion, or to slow down this conversion to frank dementia. And what they've also found is that those with amnestic mild cognitive impairment with depression, they had higher amyloid beta deposition, especially in the frontal lobe, compared to those who did not have depression. And of course, dysfunction of the frontal lobe can cause worsening of executive function, worsening of apathy, and worsening of their cognition as well, ultimately. So how do we treat late life depression? As I mentioned earlier, late life depression really responds lesser to antidepressant therapy compared to early onset depression, but antidepressant therapy is still highly efficacious. The NNT, or number needed to treat antidepressants in late life depression, is about 8. And that's pretty impressive. Okay, studies have shown that augmenting therapy with either lithium, aripiprazole, or even Ritalin are actually quite efficacious. And I've used Ritalin quite a bit in my older patients, especially those who have apathy. And I find that it really gives them that sparkle back again, especially in the mornings. Okay, antidepressants have also shown to reduce the amyloid load in the brain. And some people have even suggested using antidepressants prophylactically to delay the conversion of amnestic MCI to dementia. That's an interesting proposition, but we don't have enough evidence to promote this to all patients. Okay, and they've also shown that that usage of antidepressants and lithium may also delay the onset of Alzheimer's disease, and you can see how it can help delay the onset based on my presentation earlier on. Okay, but unfortunately, antidepressants are not that effective in the depression of dementia. So when people already have dementia and they have concomitant depression, antidepressants are unfortunately not that effective. I still use them, but their effect size is not as great as those without dementia. Okay, and of course, this is just the pharmacological treatment of late life depression. There's also the non-pharmacological treatment of depression. And as what Dr. Christine was mentioning earlier, I also advocate exercise to my older patients. CBT is also very useful, cognitive behavioral therapy, and also support from their environment and from their family, and also the various social networking that they have is also extremely important. Okay, and just a short note on ECT in late life depression. ECT stands for electroconvulsive therapy, is most effective therapy in depression. The remission rates are as high as 80%. Okay, and it's very safe to use even in those patients who've had history of stroke, Parkinsonism, and yes, even dementia. Okay, the mean number of ECTs to achieve remission was about 7. Okay, so we do ECT very frequently in our inpatient unit, and it's very efficacious in late life as well. And this I've spoken about this just now. Various non-pharmacological treatments we have for depression. Now, very quickly, I'd like to move on to late onset bipolar disorders. This refers to the onset of bipolar disorders up to the age of 50. And the prevalence really is 0.1%. So really not as great as late life depression. Okay, and of course, depression and schizophrenia are much more prevalent than late onset bipolar disorders, about 14 times more common, but still is not that infrequently seen. I've in fact encountered late onset bipolar disorders quite a few times in my practice. Now, is associated with more neurological impairments, a lot like late life depression as well. This subset of patients tend to abuse substance much lesser compared to younger counterpart. They have more mixed features. And what I mean by mixed features is that if they are in their manic phase, they do have quite a lot of depression as well. If they are in their depressive phase, they have quite a lot of manic or hypomanic symptoms. They have a lower family history of bipolar disorder, and of course, they have greater structural change in the brain. Okay, they have more cortical atrophy and white matter hyperintensity. So really, this changes in brain matter and changes in brain circuitry is the common denominator of mood disorders in older persons. Now, there is a concept of primary versus secondary mania, okay, which is important to understand in late onset bipolar disorders. Primary mania refers to bipolar disorder according to the DSM-5, okay, but secondary mania refers to organic mania. That means manic presentation that results from an organic cause, such as medication or such as metabolic causes, or even neurological changes. Sometimes a patient is having for example, encephalitis or having a brain tumor, they could have manic presentation, or even a patient post-stroke could have a manic presentation, especially in the right side of the brain. And these patients who present this way, that means those who have symptoms of mania, for example, elated mood, elated self-esteem, increased goal-directed activity, aggression. We need to look hard for a secondary cause before we pin the cause to bipolar disorders. Okay, and interestingly, up to 71% of older persons with mania actually had a comorbid neurological disorder. Now, these are the various brain lesions that have been associated with mania. Just for your information, it involves the bilateral orbitofrontal areas, which also control impulsivity, the right temporoparietal area, right basal and medial temporal lobe, and also the basal ganglia as well. And we see in patients with Binswanger's disease, where there is widespread atherosclerosis of the small vessels in the brain, they're also more inclined to develop mania. So again, in mania and depression, there are a lot of structural or ischemic changes in the brain. Okay, so we need to look hard for these changes. Now, mania can also be a prodrome of dementia, particularly if not a temporal dementia. Sometimes it can be the presenting features. Oftentimes, I see, or perhaps not oftentimes, once in a while, we have a patient who comes in with bipolar mania, or we think he has bipolar mania. And after some time, after a few months, we eventually revise the diagnosis to dementia. And I've had 1 or 2 patients which have had to do that. And these patients actually have more persistent cognitive impairment and have significant brain tissue losses in the prefrontal and also hippocampal area. So how do we tell the difference? We will need neuroimaging will certainly be of great assistance in telling the difference, because in older persons, it's sometimes a fine line between diagnosing bipolar disorder and diagnosing a prodrome of dementia. Now, assessment of late onset bipolar disorders, just very quickly, we need to first of all exclude neurocognitive disorders, exclude all other organic pathologies first, be inclusive, have an open mind, take a thorough history. And late onset bipolar disorder is often a diagnosis of exclusion after you've done a very thorough physical examination and also ruled out all organic pathology. What are the considerations when we start treatment in older persons? We have to understand that they have reduced capacity to metabolize drugs because of reduction in liver function. They have reduced clearance by the kidneys as well. They're more sensitive to side effects by drugs, more drug-drug interaction because they're on so many medications. And also they have the presence of age-related psychosocial problems. For example, they can't drive for their appointments, they can't make it on time for their appointments. Sometimes they forget about their appointment. So we need to dose this medication or choose the medications after we have considered all these factors. I have another 2 more slides. Just bear with me. The treatment for late onset bipolar disorder, pretty much the same as our younger counterparts. Give them a mood stabilizer and atypical antipsychotics. I would prefer sodium valproate compared to lithium because lithium can affect the kidney, and older persons have sometimes impaired kidney function. Dose range for sodium valproate, I'll dose it a bit lower, 250 milligrams to 1000 milligrams per day. Okay, use lithium cautiously because it can precipitate both thyroid and kidney dysfunction. Okay, if you want to use lithium, dose should be reduced by 30 to 50%, and the target lithium level in the geriatric population is 0.4 to 0.7 millimoles per liter. For the older persons, for the younger population is 0.8 to 1.2. Okay, older adults are more sensitive to medications, and therefore start low and go very slow. Okay, not just slow, but very slow. This is my last slide. I'd just like to share with you this case report that I published sometime last year, where we applied ECT to one of our patients with late onset bipolar mania, and this lady was 91 years old, who came in with a manic presentation. She was elated, aggressive, a lot of energy, couldn't sleep at night. And we found that she was actually the oldest person to have ECT in the Southeast Asian region. So we managed to do ECT quite safely and quite efficaciously for this lady, and we published our experience in the Asian Journal of Psychiatry to show that ECT is very safe and very efficacious, even for a 91-year-old lady. And she actually did not have any cognitive impairment after the procedure, and she was the oldest lady in the Southeast Asian region to receive ECT with bipolar. With that, I'd like to end my presentation. I'll be glad to take any questions if you have them.
Yeah, thank you, Dr. Benedict. We do have a number of questions. So,
yeah, sure, no problem.
Right, so the first one is from Prof. Mary. Is the realizations in the individual that they are not able to function as well as previously could be one of the possible triggers of the late life depressions?
Yeah, I don't think that's a trigger, but it certainly could it could perpetuate the illness. Yeah, so not knowing that they have it or not knowing that they're able to perform certainly could perpetuate the illness and prevent them from seeking help. But I don't think it could trigger it though. The triggers of late life depression are usually environmental and also concomitant medical illness, which are not so well controlled.
Yeah, that's right. Okay, the next questions I think is the questions that a lot of people are concerned is how could we actually prevent this? All right, so the late life depressions and dementia, can we actually prevent through the diet?
Yeah, certainly. So yeah, I would advocate lifestyle changes and also dietary modification. So try and stick to a Mediterranean diet. That's really excellent. Not our Malaysian, Asian diet is really very, very destructive, So try and eat more fatty fish, more salmon, more tuna, more legumes, cereals, whole meal, more omega-3, those kind of things. Not You're right. They're not so much carbohydrates. And now what I found is that taking turmeric supplementations also has been quite helpful. And even the Western nations are doing a lot of studies now to show that turmeric supplementation is a very good anti-inflammatory agent. And it's also quite good in preventing dementia as well.
Oh, good. So we are all going to start that.
Yeah.
Right. So the next question is like, do we refer older adults with depressions for psychological counseling? And does it help? And right, could they have a possible if they already have a cognitive impairment? So how effective is the psychological counseling?
Yeah, that's a good question. I think once they have cognitive impairment, then maybe counseling may not be as effective, as in younger patients. So really, it's based on the patient profile. What I find in treating patients with late life depression is that it's quite organic. So you've got to really treat the comorbid medical illnesses, you've got to treat the risk factors, and you've got to engage the family support. I think that's more important than going for formal therapy in the form of counseling. Because once they have cognitive impairment, they can't really participate in the therapy themselves. But of course, those who don't have, then counseling and therapy would be most helpful. So the first thing I'll do is to optimize the sugar, optimize the blood pressure, optimize the cholesterol, explain to them about lifestyle changes, get them engaged in a fruitful discussion with the family members as well, to so that they take action on their own health and become more proactive. Of course, start antidepressants for them as early as possible.
Yeah. So another person is asking, right? Oh well, can early onset depressions occur in those more than 65 years old? How do you differentiate this and late onset depressions?
Yeah. So late onset simply means that the first episode or index, the index episode starts at 65 and above. If they've had a history of depression before 65, then you don't use the term late onset depression. Okay, so if they had an episode of depression when they were in their 20s or 30s, then they had another occurrence after 65, then you wouldn't say late onset. So that's how you differentiate it.
Yeah, and the management, I think, right, you have mentioned it, right?
Yeah, correct. So late onset, as I said, it's not as straightforward as adult onset. You've got to take into account the inflammatory state in the brain. So because of that, lifestyle changes is extremely important. I can't emphasize that enough. Exercising and eating right is going to go a long way in helping with late life depression, and also treating the loneliness, especially in this pandemic. I find that older persons are really suffering because they're so lonely. That actually has also increased the incidence of dementia the past 2 years. So treating that also helps with late life depression.
Yeah, definitely.
Social networking.
Yeah, the social networkings, right? So the last question is like, is late onset bipolar disorder more common in people with a family histories of bipolar disorders?
Yeah, so not necessarily for late onset. Yes, they don't really have so much of family history compared to adult onset bipolar. So so compared to the younger ones, those with late onset do not really have this genetic contribution, not as often. So it can occur sporadically. And again, if you ask why it happens, is because of it's more neurologic, and there are more changes to the brain structure and brain parenchyma, oftentimes because of silent strokes and other kinds of impairments to the brain.
Rather than the functioning.
Yeah, correct.
Right. Okay,
yeah,
right.
rather than genetic factors. Yeah.
Yeah. Right. Thank you, Dr. Benedict. So
You're most welcome.
Please have learned a lot from you. With that, right, we have already answered all the questions and in the Q&A box. So with that, right, I would say that we have finished our sessions, and right, so we're going to close this UMHealth breakfast. So stay tuned for the next week. They will email you the topics and the departments that were involved this Friday through your emails. So see you then.
Okay, thank you. Thanks, everyone.
Bye.
Thank you. Bye.
Thank you. Bye.